Welcome to this video entitled, Nosocomial Respiratory Infections. We will begin with a few definitions. The designation nosocomial respiratory infection refers to tracheobronchitis and pneumonia caused by pathogens highly prevalent in hospital settings and developing at least 48 hours after hospital admission. Nosocomial tracheobronchitis is characterized by signs of respiratory infection, such as an increase in the volume and purulence of respiratory secretions, fever, and leukocytosis, without radiologic infiltrates suggestive of consolidation on the chest film. Nosocomial pneumonia comprises pneumonia developing in non-intubated patients, ventilator-associated pneumonia, abbreviated as VAP, and healthcare-associated pneumonia, abbreviated as HCAP. Ventilator-associated pneumonia commonly develops in patients who receive invasive mechanical ventilation. Healthcare-associated pneumonia is a more recently recognized clinical entity that is defined in the latest guidelines of the American Thoracic Society for the Diagnosis and Treatment of Nosocomial Pneumonia. Healthcare-associated pneumonia develops in patients who are not hospitalized but are at risk for colonization by pathogens present in hospital settings, including multiple drug-resistant, abbreviated as MDR, microorganisms. Next we will look at the epidemiology. Let's begin with incidence. Nosocomial tracheobronchitis occurs in 3% to 10% of tracheally intubated patients and often precedes the development of ventilator-associated pneumonia. Nosocomial pneumonia is the second most common nosocomial infection and the leading cause of death from hospital-acquired infections in critically ill patients. Most recent studies report a ventilator-associated pneumonia density rate of approximately 9 to 10 cases per 1,000 ventilator days. Nevertheless, those rates differ greatly according to the characteristics of the studied population. The risk of ventilator-associated pneumonia is approximately 1% per day on mechanical ventilation and changes over time, being 3% the first 5 days on mechanical ventilation, 2% from days 5 to 10, and 1% for the remaining days. We will now discuss impact on outcomes. Nosocomial tracheobronchitis in hospitalized patients is associated with longer duration of mechanical ventilation and intensive care unit (ICU) stay. Indeed, tracheobronchitis is associated with increased sputum production, which often leads to weaning difficulties and extubation failure. Nevertheless, tracheobronchitis is not associated with worse survival. The crude mortality rate for nosocomial pneumonia may be as high as 30% to 70%, although several cofactors influence mortality, making it extremely difficult to determine the true disease-attributable mortality. Indeed, the heterogeneity between patient populations, microbial patterns, antibiotic treatment, and diagnostic methods challenge precise estimate of mortality. Several case-matching studies have estimated that 1/3 to 1/2 of all ventilator-associated pneumonia-related deaths are a direct result of the infection, with a higher mortality rate in cases caused by Pseudomonas aeruginosa or Acinetobacter species and associated with bacteremia. Higher mortality is associated in particular with late-onset ventilator-associated pneumonia, specifically when the initial empirical antimicrobial therapy regimen is inadequate. We will now discuss pathogenesis role of endotracheal tube. Pulmonary aspiration of colonized oropharyngeal secretions across the tracheal tube cuff is the main pathogenic mechanism for development of tracheobronchitis and ventilator-associated pneumonia. The endotracheal tube, abbreviated as ET, commonly used in the ICU for long-term mechanically ventilated patients, includes a high-volume, low pressure, abbreviated as HVLP, cuff, which is approximately 2 to 3 times larger than the trachea. Hence, when the cuff is inflated within the trachea, folds invariably form along the cuff surface, which leads to aspiration of oropharyngeal secretions. Several respiratory defense mechanisms are severely impaired after tracheal intubation. 1. The endotracheal tube completely bypasses the anatomic barrier provided by laryngeal structures, creating a direct conduit by which bacteria can be aspirated and reach lower airways. 2. Presence of the tube hinders cough. And 3. Inflation of the endotracheal tube cuff within the trachea drastically lowers mucociliary velocity. Additionally, the endotracheal tube is commonly made of polyvinyl chloride, PVC. With this material, bacteria easily adhere to the internal surface of the tube to form a complex structure called biofilm. Bacteria present within the biofilm have survival advantages and may be a source of persistent infection. And now we will discuss sources of colonization. Exogenous versus endogenous sources. Patients can be colonized exogenously by contaminated respiratory equipment, the hospital environment, and the hands of the attending staff. Thus, healthcare personnel should be adequately trained in infection control and preventive strategies. Strict sterilization protocols and hand washing with alcohol-based solutions should be implemented. And finally, lower patient-nurse ratios can be expected to promote optimal care with consequent lower colonization rates. Nevertheless, endogenous colonization is believed to be the primary pathogenic mechanism for nosocomial respiratory infection development. In the hospitalized patient, the oral flora may shift to a predominance of aerobic gram-negative pathogens, Pseudomonas aeruginosa, and methicillin-resistant Staphylococcus aureus, abbreviated as MRSA. After aspiration of bacteria-laden oropharyngeal secretions and colonization of the airways, the occurrence of respiratory infection depends on the size of the inoculum, the patient's functional status, and the competency of host defenses. We will now focus on the stomach. According to the gastropulmonary hypothesis of colonization, the stomach of patients being treated in ICUs often is colonized by pathogens as a consequence of alkalinization of gastric contents by enteral nutrition and drugs. Continuous gastroesophageal reflux facilitates translocation of microbes into the oropharynx, which are then aspirated across the endotracheal tube cuff. Early studies have shown that in tracheally intubated patients, gastric pH higher than 4 is consistently associated with pathogenic colonization of the stomach. Conclusive evidence is still lacking, however, for an association of gastric colonization with increased risk of pneumonia, and some investigators have not found a relationship with bacteria causing lung infection as first originating in the stomach. We will now focus on etiologic agents. Nosocomial respiratory infections may be caused by a variety of pathogens, and often more than one pathogen may be isolated. Microorganisms responsible for those infections differ according to the studied population, the duration of hospital stay, and the specific diagnostic methods used. Nosocomial respiratory infections are commonly caused by aerobic, gram-negative bacilli, such as Pseudomonas aeruginosa, Escherichia coli, Klebsiella pneumoniae, or Acinetobacter species, whereas Streptococcus aureus is the predominant isolated gram-positive pathogen. In a recent report by Respiratory and colleagues, the etiology of nosocomial pneumonia was investigated for invasively versus non-invasively ventilated patients managed in the ICU. Of interest, no significant differences were found. except for a higher proportion of Streptococcus pneumoniae in the non-invasively ventilated patients. These results imply that prevalence rates for nosocomial pathogens are similar in intubated and non-intubated patients, and that the use of empirical therapy likely to be active against them is warranted. Underlying diseases may predispose patients to infection with specific organisms. For instance, patients with chronic obstructive pulmonary disease, COPD, are at increased risk for Haemophilus influenza, Moraxella catarrhalis, Pseudomonas aeruginosa, or Streptococcus pneumoniae infections. Patients with acute respiratory distress syndrome, ARDS, are at higher risk for development of VAP caused by Staphylococcus aureus, Pseudomonas aeruginosa, and Acinetobacter baumannii. Finally, patients with traumatic injuries and neurologic disorders are at increased risk for Staphylococcus aureus, Haemophilus, and Streptococcus pneumoniae infections. Identification of pathogens resistant to multiple drugs is extremely important in order to guide appropriate antibiotic treatment. Potential multi-drug resistant pathogens are Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, Acinetobacter species, Stenotrophomonas multifilia, Burkholderia cepacia, and extended-spectrum beta-lactamase pro-duking, extended-spectrum beta-lactamase positive, Klebsiella pneumoniae. Conversely, Streptococcus pneumoniae, Haemophilus influenza, methicillin-sensitive Staphylococcus aureus, and antibiotic-sensitive Enterobacteriaceae organisms are not considered to be multi-drug resistant pathogens. The incidence of multi-drug resistant pathogens is closely linked to local factors and varies widely from one hospital to another. Accordingly, practitioners must be aware of the most prevalent microorganisms in their own clinical facilities and geographic regions to avoid the administration of initial inadequate antimicrobial therapy. Legionella pneumophila as a cause of nosocomial pneumonia should be considered, particularly in immunocompromised patients. Anaerobes may potentially cause nosocomial infections, but often those pathogens are identified in association with aerobic pathogens, and their role is still considered controversial. Nosocomial infections are rarely caused by a fungus. Candida species and Aspergillus fumigatus are the most common isolated fungi, predominantly in immunocompromised patients. Finally, herpes simplex virus type 1 and cytomegalovirus, CMV, are the most common viruses identified as a cause of respiratory infections in hospitalized patients. Of note, CMV pneumonia was found to be consistently associated with worse outcomes in patients managed in the ICU. We will now consider prevention. Nosocomial respiratory infections are associated with high morbidity and mortality and constitute an important burden for the healthcare system. Therefore, appropriate preventive strategies, summarized in Box 27.1, should be implemented to reduce overall incidence of those diseases. Approaches with proven efficacy in reduction of nosocomial respiratory infections should be grouped and implemented as a bundle, because together they are expected to result in a better outcome than when implemented individually. Box 27.1 summarizes preventive strategies for nosocomial pneumonia, which entails the following. 1. Implementation, as a bundle, of nosocomial pneumonia preventive strategies that have proven efficacy in reducing morbidity and mortality. 2. Implementation of educational programs for caregivers and frequent performance feedbacks and compliance assessment. 3. Strict alcohol-based hand hygiene. 4. Avoidance of tracheal intubation and use of non-invasive ventilation when indicated. 5. Daily sedation vacation and implementation of weaning protocols. 6. No ventilatory circuit tube changes unless the circuit is soiled or damaged. 7. Use of tracheal tube with cuff made of novel materials and shapes. 8. Use of silver-coated tracheal tube. 9. Application of low level of PEEP during tracheal intubation. 10. Aspiration of subglottic secretions. 11. Internal cuff pressure maintained within the recommended range and carefully controlled during transport of patients outside ICU setting. 12. Oral care with chlorhexidine. 13. Avoidance of stress ulcer prophylaxis in patients at very low risk for gastrointestinal bleeding, with use of sucralfate considered when indicated. 14. Semi-recumbent patient positioning. 15. Continuous lateral rotation therapy. 16. Post-pyloric feeding in patients who have impaired gastric emptying. And 17. Selective digestive decontamination for patients requiring mechanical ventilation for longer than 48 hours. We will now focus on general prophylactic measures. Maintaining high levels of current knowledge on pathophysiology of nosocomial infections and preventive strategies in clinical healthcare personnel can be effective in reducing incidence of those diseases. Respiratory care practitioners and nurses should be the primary recipients of ongoing education programs, and frequent performance feedback and compliance assessment should be undertaken. The World Health Organization, WHO, has endorsed hand hygiene as the single most important element of strategies to prevent healthcare-associated infections. Overall, most of the studies conducted in ICUs have shown consistent reduction in nosocomial infection rates through implementation of alcohol-based hand hygiene. Daily interruption or lightening of sedation, as a strategy to avoid consistent impairment of respiratory defenses, as well as the avoidance of paralytic agents, is highly recommended. We will now focus on non-invasive ventilation. Tracheal intubation and mechanical ventilation constitute the main risk for nosocomial respiratory infections and should be avoided whenever possible. Non-invasive ventilation is an attractive alternative for patients with acute exacerbations of COPD or acute hypoxemic respiratory failure, and for some immunocompromised patients with pulmonary infiltrates and respiratory failure. And now we will discuss tracheal tube cuff. Novel endotracheal tube cuffs made of polyurethane, silicone, and latex have been developed and tested in laboratory and clinical trials. Particularly, the polyurethane cuff forms smaller folds on its inflation, so that the risk of aspiration of secretions above the cuff is less. The shape of the cuff may also play a role in prevention of aspiration. In comparison with standard cuffs with cylindrical shape, cuffs designed with a smooth tapering shape allow elimination of folds for a full section of the trachea cuff contact zone, irrespective of the cuff material. Nevertheless, the clinical evidence on the efficacy of these novel tapered cuffs is still lacking. It is important to maintain the internal pressure of the endotracheal tube cuff pressure between 25 to 30 centimeters of water, particularly when low levels of positive end expiratory pressure, abbreviated as PEEP, are applied, in order to prevent both macro leakage of contaminated secretions into the lower airways and tracheal injury. We will now focus on tracheal tubes coated with antimicrobial agents. Coating the endotracheal tube with antimicrobial agents, such as silver, is a promising strategy to prevent biofilm formation within the tube with consequent ventilator-associated pneumonia. The North American silver-coated endotracheal tube, abbreviated as NASCENT, randomized trials studied 2,003 patients, expected to require mechanical ventilation for more than 24 hours, who were randomized to be intubated with either a silver-coated or a conventional tube. Use of the silver-coated endotracheal tube was associated with a lower incidence of microbiologically confirmed ventilator-associated pneumonia, for a relative risk reduction of 35.9%. We will now discuss aspiration of subglottic secretions. Preventive aspiration of colonized subglottic secretions through dedicated endotracheal tubes reduces hydrostatic pressure exerted above the cuff, potentially preventing macro leakage across the cuff. Subglottic secretion drainage has been shown to reduce the incidence of ventilator-associated pneumonia by nearly half, primarily by reducing both early and late-onset pneumonia. We will now discuss body position. Intubated patients are at higher risk for gastropulmonary aspiration when placed in the supine position, that is 0 degrees, than in a semi-recumbent position, particularly when they are enterally fed. The American and European guidelines strongly suggest that intubated patients should be preferentially kept in the semi-recumbent position, that is 30 to 45 degrees, rather than supine, that is 0 degrees, to prevent aspiration, especially when the patient is receiving enteral feeding. We will now discuss stress ulcer prophylaxis in intubated patients. In the ICU, stress ulcer prophylaxis usually is achieved with either sucralfate, histamine type 2 receptor blockers, H2 blockers, or proton pump inhibitors, abbreviated as PPIs. Sucralfate is the only agent that potentially prevents stress gastrointestinal ulceration without raising gastric pH. Clinicians must weigh the potential benefit of sucralfate, with potentially less ventilator-associated pneumonia and more gastrointestinal bleeding, against that of H2 blockers or proton pump inhibitors, with potentially more ventilator-associated pneumonia and less gastrointestinal bleeding, and probably should limit stress ulcer prophylaxis to high-risk patients. We will now focus on modulation of oropharyngeal and gastrointestinal colonization. Extensive efforts have been devoted to modulate oropharyngeal flora of hospitalized patients and reduce the risk for aspiration of pathogens. Oropharyngeal decontamination with chlorhexidine effectively reduces ventilator-associated pneumonia, particularly among patients managed in cardiothoracic ICUs. Results in non-cardiac ICU populations are more uncertain, and significant reductions in ventilator-associated pneumonia rates have been achieved only when chlorhexidine was used at concentrations of 2%. Selective decontamination of the digestive tract, abbreviated as SDD, has been used as a preventive strategy against nosocomial pneumonia for almost 3 decades. The selective digestive decontamination regimen comprises a combination of non-absorbable antibiotics active against gram-negative pathogens, e.g., tobramycin, polymyxin E, plus either amphotericin B or nystatin, administered into the gastrointestinal tract in order to prevent oropharyngeal and gastric colonization with aerobic gram-negative bacilli and candida species, while preserving the anaerobic flora. Some regimens include a short course of systemic antibiotics, most commonly cefotaxime, in addition to non-absorbable gastrointestinal antibiotics. Selective digestive decontamination reduces the incidence of ventilator-associated pneumonia, and it is the only ventilator-associated pneumonia preventive strategy that has shown survival benefits in patients managed in the ICU. The long-term effects of selective digestive decontamination on emergence of bacterial resistance and risk of superinfections are still controversial. We will now discuss diagnosis. Nosocomial pneumonia should be suspected in patients with a new or progressive infiltrate on lung imaging associated with at least two of the following clinical features. 1. Fever. 2. Leukocytosis or leukopenia. And 3. Purulent airway secretions. The presence of these clinical signs, without a new infiltrate on the chest film, suggests nosocomial tracheobronchitis. In patients managed in the ICU, clinical signs suggestive of pneumonia often are too nonspecific to be of diagnostic value. Moreover, the chest radiograph often is difficult to interpret in those patients. Indeed, when infiltrates are evident, it is challenging to differentiate among cardiogenic and non-cardiogenic pulmonary edema, pulmonary contusion, atelectasis, and pneumonia. Clinical variables often are evaluated as a group, to improve specificity of the clinical diagnosis. The Clinical Pulmonary Infection Score, abbreviated as CPIS, is based on clinical assessments, pulmonary radiographic findings, and semi-quantitative culture of tracheal aspirate, each worth between 0 and 2 points, as shown in Table 27.1. A minimum value of 6 is the threshold to identify patients with pneumonia. Nevertheless, the value of clinical pulmonary infection score remains to be validated in a large prospective study, especially in patients with bilateral pulmonary infiltrates. The presence of bacteria in the lower airways of intubated patients is not sufficient to diagnose true lung infection, because the tracheobronchial tree of mechanically ventilated patients frequently is colonized by enteric gram-negative bacilli. Many sampling procedures are available, such as sputum collection, endotracheal aspiration, bronchoalveolar lavage, abbreviated as BAL, and protected specimen brush, abbreviated as PSB, procedures. In addition, several microbiologic techniques can be used, including gram staining and intracellular organism count from specimens obtained by tracheal aspiration and BAL. Each diagnostic technique has advantages and limitations and provides different levels of diagnostic specificity and sensitivity. Qualitative cultures of endotracheal aspirates yield a high percentage of false positive results owing to frequent bacterial colonization of the proximal airways. Conversely, quantitative culture techniques of endotracheal aspirates may have an acceptable overall diagnostic accuracy. When patients develop pneumonia, pathogens are present in the lower respiratory tract secretions at concentrations of at least 10 power 5 to 10 power 6 colony-forming units, CFU, per milliliter, and contaminants generally are present at less than 10 power 4 colony-forming units milliliter. The current proposed ventilator-associated pneumonia diagnostic threshold is 10 power 6, 10 power 4, and 10 power 3 colony-forming units milliliter for tracheal aspirates, BAL fluid, and protected specimen brush samples, respectively. Likewise, in a patient without radiographic pulmonary infiltrates, tracheal aspirates colonized at a concentration of at least 10 power 6 colony-forming units milliliter may suggest tracheobronchitis. Pause the video and carefully scrutinize Table 27.1 Clinical Pulmonary Infection Score, abbreviated as CPIS, before advancing to the next slide. We will now discuss diagnostic strategies for nosocomial respiratory infection. An ideal diagnostic strategy for patients suspected on clinical grounds to have nosocomial respiratory infection should achieve the following objectives. 1. Accurately identify patients with true pulmonary infection and isolate the causative microorganisms, to allow prompt initiation of appropriate antimicrobial treatment and then optimization of therapy based on susceptibility studies of the pathogens. 2. Identify patients with extrapulmonary sites of infection. And 3. Withhold and/or withdraw antibiotics in patients without infection. The diagnosis of nosocomial pneumonia begins with clinical suspicion triggered by suggestive findings. The presence of a new or progressively worsening radiographic infiltrate plus clinical criteria constitutes a firm basis for further investigation. Either of two diagnostic algorithms can be used, clinical or bacteriologic. The clinical approach recommends treating every patient suspected to have a pulmonary infection with new antibiotics, even when the likelihood of infection is low, as shown in Figure 27.1. Nevertheless, samples of respiratory secretions such as endotracheal aspirate or sputum should be obtained before the initiation of antibiotic treatment. In this strategy, the selection of appropriate empirical therapy is based on risk factors and local resistance patterns. The etiology in each case of pneumonia is defined by semi-quantitative cultures of endotracheal aspirates or sputum, often with additional microscopic examination of the gram stain. Antimicrobial therapy is adjusted according to culture results or clinical response. Semi-quantitative culture of tracheal aspirates has the advantage that no specialized microbiologic techniques are required, and the sensitivity is high. This clinical strategy provides antimicrobial treatment to a majority of the patients with suspected pneumonia and yields a low rate of false negative results. Still, if the tracheal aspirate culture does not demonstrate pathogens and the patient has not received new antibiotics within the previous 72 hours, the diagnosis of pneumonia is unlikely. The main drawback of this strategy is that the high sensitivity of semi-quantitative cultures of tracheal aspirates leads to overtreatment, with institution of unnecessary antibiotics in patients with false positive results. The bacteriologic strategy is based on the results of quantitative cultures of lower respiratory secretions, as shown in Figure 27.2. The procedure used to collect the samples, endotracheal aspirate, BAL fluid, or protected specimen brush, may be invasive, bronchoscopic, or non-invasive, blind procedures. The strategy reduces risks for overuse of antibiotics, because quantitative cultures yield fewer microorganisms above the threshold in comparison with semi-quantitative cultures. Among the disadvantages of the bacteriologic strategy is the possibility of obtaining false negative results, which leads to delayed antibiotic treatment in patients with pneumonia. Moreover, results obtained using the microbiology strategy may lack reproducibility, and often no microbiologic information is available at the time of initiation of empirical antibiotic therapy. Pause the video and carefully scrutinize Figure 27.2 invasive and quantitative culturing strategy for the diagnosis and management of ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Figure 27.2 invasive and quantitative culturing strategy for the diagnosis and management of ventilator-associated pneumonia before advancing to the next slide. We will now discuss practical implementation of a diagnostic strategy in suspected nosocomial respiratory infection. In practice, the development of local clinical guidelines can combine both clinical and bacteriologic strategies. In mechanically ventilated patients, the presence of an infiltrate on the chest radiograph differentiates between the possible presence of pneumonia and tracheobronchitis. The next step is to obtain samples from the lower respiratory tract. Before initiation of antibiotic treatment or change in regimen, even though it should not delay the administration of antibiotic therapy, particularly for septic patients. When indicated, additional samples should be collected for microbiologic analyses, such as blood, pleural fluid, and, in case Legionella pneumophila or Streptococcus pneumoniae infections are suspected, urine should be obtained. With clinical findings suggestive of pneumonia, CPIS should be calculated to improve objective assessment of the clinical parameters. See Table 27.1. Pause the video and carefully scrutinize Figure 27.3 illustrating evolution of the potentially pathogenic microorganisms present in the oropharyngeal flora, related to comorbidity, antibiotic treatment, and colonization pressure before advancing to the next slide. We will now discuss treatment. Once the clinical decision to initiate antimicrobial therapy for nosocomial respiratory infection has been made, the following issues should be considered, both to achieve the best antimicrobial efficacy and to reduce overuse of antibiotics. 1. The most likely etiologic microorganisms. 2. Choice of the empirical antimicrobials likely to be active against these microorganisms. 3. The adjustment of therapy after microbiologic results are in and with duration of treatment. An important point is that the indiscriminate administration of antimicrobial agents may contribute to the emergence of multi-resistant pathogens and increase the risk of severe superinfections with increased morbidity and mortality, as well as exposing the patient to antibiotic-related adverse effects and higher costs. On the other hand, correct and prompt treatment of nosocomial respiratory infections results in better patient survival. We will now focus on the likely etiologic microorganisms. The selection of initial antimicrobial therapy needs to be tailored to the local prevalence of pathogens and antimicrobial patterns of resistance of the institution. The dynamics of change of oropharyngeal flora during hospital stay is depicted in Figure 27.3. Changes in oropharyngeal flora tend to occur progressively, so that the presence of microorganisms during one stage often overlaps with the next stage. Pause the video and carefully scrutinize Table 27.2 summarizing initial empirical antibiotic treatment in nosocomial and ventilator-associated pneumonia of early onset in patients without risk factors for infection by multi-drug-resistant pathogens before advancing to the next slide. We will now discuss choice of the empirical antimicrobials likely to be active against causative microorganisms. The latest guidelines of the American Thoracic Society and the Infectious Diseases Society of America, ATS, IDSA, for the management of adult patients with nosocomial pneumonia recommend that the selection of empirical antibiotic therapy for each patient should be based on the timing of onset and presence of risk factors for multi-drug-resistant pathogens, that is antimicrobial therapy in preceding 90 days, current hospitalization of 5 days or more, high frequency of antibiotic resistance in the community or in the specific hospital unit, hospitalization for 2 days or longer within the preceding 90-day period, residence in a nursing home or extended care facility, home infusion therapy, including antibiotics, chronic dialysis within 30 days, home wound care, multi-drug-resistant pathogen carrier status or infection in a family member, and immunosuppressive disease and/or therapy. The antibiotics recommended in the current ATS, IDSA guidelines are shown in Tables 27.2 and 27.3. Broad-spectrum empirical antibiotic therapy should be rapidly de-escalated as soon as microbiologic data become available, to limit the emergence of resistance in the hospital. We will now look at patients with late-onset pneumonia or early-onset pneumonia with risk factors for multi-drug-resistant bacteria. Patients with late-onset pneumonia or early-onset pneumonia with risk factors for multi-drug-resistant bacteria may be infected with resistant gram-negative bacilli. Priority should be given to treatment with a beta-lactam. Choice of the beta-lactam agent should take into account the following factors. 1. In vitro susceptibility of Pseudomonas aeruginosa in the ICU. 2. The prevalence of Enterobacteriaceae organisms producing extended-spectrum beta-lactamus. 3. The results of previous cultures. And 4. Antibiotics already received by the patient. An anti-pseudomonal beta-lactam regimen would include a third-generation cephalosporin, ceftazidime or cefepam, piperacillin tazobactam, or a carbapenem, imipenem or meropenem. See Table 27.3. Pause the video and carefully scrutinize Table 27.3 summarizing initial empirical antibiotic treatment for nosocomial and ventilator-associated pneumonia of late onset or in patients with risk factors for infection by multi-drug-resistant pathogens and any degree of severity before advancing to the next slide. Pause the video and carefully scrutinize Table 27.3 summarizing initial empirical antibiotic treatment for nosocomial and ventilator-associated pneumonia of late onset or in patients with risk factors for infection by multi-drug-resistant pathogens and any degree of severity before advancing to the next slide. We will now discuss antimicrobial therapy in special situations. The addition of antibiotics with activity against methicillin-resistant Staphylococcus aureus depends on the local prevalence of methicillin-resistant Staphylococcus aureus, the presence of risk factors for methicillin-resistant Staphylococcus aureus, and the severity of infection. In geographic areas with documented presence of community-acquired methicillin-resistant Staphylococcus aureus, severe pneumonia with radiologic images of cavitation and presence of gram-positive cocci in respiratory secretions, empirical treatment with linezolid or vancomycin may be appropriate. Infections by Legionella pneumophila serogroup 1 can be diagnosed by a Legionella urinary antigen test. A fluoroquinolone or a macrolide would be an appropriate agent for treatment of Legionella pneumophila infection. We will now focus on modifications of therapy and duration of treatment. After 72 hours, treatment should be adjusted in accordance with the microbiologic results. The initial beta-lactam should be continued if the microorganism is susceptible to the empirical beta-lactam originally prescribed. If it is not, another beta-lactam, possibly a carbapenem, may be introduced. The empirical antibiotic active against methicillin-resistant Staphylococcus aureus should be discontinued if the presence of this pathogen is not confirmed by cultures. Discontinuation of the fluoroquinolone and especially the aminoglycoside should be considered after 3 to 5 days of treatment. The bactericidal activity of aminoglycosides and fluoroquinolones leads to a rapid reduction in the bacterial load during the first days of treatment. Thereafter, monotherapy may be sufficient. This approach would decrease emergence of resistant mutants and minimize nephrotoxicity caused by aminoglycosides. A majority of infections can be effectively treated with regimens lasting up to 8 days. 4 special situations may justify prolonged treatment. 1. Infection by microorganisms that may multiply in the cellular cytoplasm, such as Legionella species. 2. The presence of biofilms or prosthetic devices. 3. The development of tissue necrosis, the formation of abscesses, or infection within a closed cavity, such as empyema. And 4. Persistence of the original infection, such as with perforation or endocarditis. If the clinical course from the pneumonia is favorable within the first 3 to 5 days of antimicrobial therapy, treatment may be withdrawn after the completion of 8 days. In cases of pneumonia produced by non-fermenting gram-negative bacilli, the eradication of these microorganisms from the bronchial secretion can be achieved with a longer regimen of up to 14 days. In patients originally suspected on clinical grounds to have ICU-acquired pneumonia, but whose CPIS is lower than 6 on the 3rd day of drug therapy, treatment may be withdrawn. In this setting, the patient probably did not have pneumonia, or the pneumonia was sufficiently mild that prolonged antibiotic treatment is not required, as shown in Figure 27.4. We will now discuss important insights for treatment of nosocomial respiratory infections. Studies have proved beneficial effects of antimicrobial treatment for patients with nosocomial tracheobronchitis being cared for in an ICU. In these patients, antibiotics can have an impact on ICU mortality rate, duration of mechanical ventilation, and ICU stay, and ultimately hinder progression of the infection to ventilator-associated pneumonia. Of importance, patients with airway colonization but without local and systemic signs of infection should not be treated. Additionally, aerosolized antibiotics can be a feasible option in such patients. There is evidence that appropriate and timely antibiotic treatment can improve outcome in patients with ventilator-associated pneumonia. Guidelines can play a significant role in accomplishing this aim. To achieve significant reductions in morbidity and mortality, however, 2 important principles should be followed. 1. The guidelines should be implemented in specific clinical settings. And 2. Antibiotic treatment regimens should be tailored to specific risk factors for acquiring multi-drug resistant pathogens. Although implementation of such guidelines is difficult, the available evidence demonstrates improvement in both management and outcome. Pause the video and carefully scrutinize Figure 27.4 illustrating a suggested flowchart for follow-up evaluation in patients with nosocomial pneumonia and ventilator-associated pneumonia before advancing to the next slide. Thank you.